Before we start, can I bring you a short message from one of our expert speakers at MIMS Learning Live North on November 26th in Liverpool. This speaker is Ms. Sangeeta Krishnan, who is a consultant ophthalmologist, and she'll be talking about eye conditions, when to manage in primary care and when to refer. I'll let her give a quick summary of what she'll be talking about.
My topic is acute eye conditions, when to manage and when to refer. I think this is a very important topic for general practitioners, as ophthalmology can be a very daunting subject. GPs see both adults and children for a myriad of eye symptoms and signs, including red eyes, acute injury, blurred vision, other visual disturbances, and double vision. My goal is to demystify all these symptoms and signs. I will be discussing common eye conditions, their presentations, and how these can be managed in a GP practice. I will be also discussing common key signs and symptoms to look out for in order to identify the more serious conditions and when to refer these to a tertiary care centre for specialist ophthalmology opinion.
That's just one of the fascinating CPD sessions at this event. Book today at mimslearninglive.com.
Hello and welcome to the Clinical Update Podcast, the podcast that brings you thought-provoking clinical education from MIMS Learning that you can fit into your busy life. I'm Sangeeta Krishnan, medical editor at MIMS Learning, and I'm delighted to be joined by MIMS Learning editor Pat Anderson.
Hello.
Today we're thinking about thinking differently. We'll talk about a topic that's been gaining significant attention both from the medical community and wider society: neurodiversity. This term's so common that my 11-year-old has heard of it, as it gets mentioned in schools quite a lot. So let's talk about what neurodiversity is and what it means in a clinical context. Why is it important that a GP know about this?
Well, when I interviewed Dr Heidi Philips, who's a GP and chair and founder of the British Association for Neurodiversity, and this was for a video learning module, she shared a statistic that surprised me. Let's have a listen.
I think it's important to recognise the terms. Neurodiversity is the whole population, and within that whole population who are neurodiverse, we do have people who fall outside the norm or the standard, and they are referred to as neurodivergent. So neurodivergence affects between 15 and 20% of our population. So when we think about patients with ADHD, with autism, with specific learning difficulties or language difficulties, then we begin to realise just how widespread so-called neurodevelopmental disorders are and how many patients GPs will actually be seeing in practice.
So neurodiverse is everyone, and neurodivergent is the 15 to 20% of us who fall outside the norm. This has huge implications for GP practice, as it means that this proportion of your practice population and your colleagues is neurodivergent. So GPs need to be aware of this.
15 to 20% is a lot. So let's touch upon a couple of the more common types of neurodivergence that we normally see in primary care, and perhaps most importantly, talk about the most sensitive and effective ways to approach these consultations. How a person comes away from a healthcare interaction can have a lasting impact on how they feel about and view themselves. So this is an important topic. So what does the word mean?
The term neurodiversity was first coined back in the late 1990s by an Australian sociologist called Judy Singer. Neurodiversity is defined as the range of differences in individual brain function and behavioural traits, regarded as part of normal variation in the human population, rather than as a deficit or a disorder.
That is such a helpful way of looking at it. So ideally, if we align with this perspective, when we view the entire population as neurodiverse, neurological differences such as those seen in autism, ADHD and Tourette's may be considered outside of neurotypical behavior, but not abnormal. It could allow us to recognize people as having a spectrum of neurological types.
Yeah, so this perspective potentially presents a very different starting point for a consultation. However, I do have to admit that on MIMS Learning, in our learning modules, we reflect the language of the medical community, which refers, for example, to autism spectrum disorder. The language used will hopefully change over time, but for the purposes of this podcast, we will reflect the language used by our expert writers.
Yes, it is an evolving field, and terms we use are not yet in line with this perspective. Hopefully, we can offer a few learning points about the perspective of neurodiverse people and language use. Neurodivergence spans through an individual's life, but is often diagnosed much later on in life, in adulthood. Also, neurodivergent conditions tend to have overlaps, so it is the norm to see patients with one neurodivergent condition also have another. The most common ones are autism spectrum disorder or ASD, attention deficit hyperactivity disorder or ADHD, dyspraxia, and dyslexia, but it also includes conditions such as Tourette's syndrome and specific learning difficulties.
ASD is a complex neurodevelopmental condition. It's used to refer to a constellation of neurodevelopmental conditions present from birth or early childhood. We have a clinical review on ASD by Dr. Carol Buckley and Professor Richard Mills, and this reveals that ASD affects 1 in 100 children and has been estimated to be 4 times higher in males than in females. It's diagnosed based on positive signs, that is the presence of certain unusual behaviours, and negative signs, that's the absence of usual behaviours. In a primary care setting, this might look like a patient who avoids eye contact and struggles to understand social cues and behavioural gestures. They may also show precocious abilities in very specific areas, insist on sameness with foods and routines, get distressed by any changes in environment, and exhibit repetitive behaviours. These symptoms can be really subtle or quite pronounced. Females tend to mask their symptoms, and that's why an ASD diagnosis may be missed in them. Autism is commonly associated with mental health comorbidities like anxiety, depression, and OCD. It's important to be mindful of this, as a patient might present with these issues and the underlying neurodivergence might be missed.
Often, as I mentioned before, neurological conditions can overlap, so it's not uncommon to have ASD co-occurring with ADHD, dyslexia, or Tourette syndrome.
Yes, Dr. Philips pointed out she thinks it's very rare to encounter so-called pure autism or pure ADHD. And she also highlighted the link between neurodivergence and physical health. So there could be links with conditions such as hypermobility, postural orthostatic tachycardia syndrome or POTS, gastrointestinal motility disorders, and metabolic disorders. And extending this thought even further, she said, as we all know, GPs frequently encounter patients with a lot of challenges like lifestyle challenges, substance misuse, alcohol dependence, difficulties with jobs, and they may not seem to have a single identifiable cause. And then she continued to say,
if we start seeing those patients through a neurodivergent lens, I think it makes more sense of their difficulties, and then we can start opening up strategies to support them.
So I thought that was really interesting from the point of view of GP's workload and some patients who GPs see who are a bit of a puzzle, and perhaps looking through the neurodivergent lens might help to solve that puzzle.
And our clinical review on ASD recommends using diagnostic tools like the Diagnostic Interview for Social and Communication Disorders, or DISCO, when considering more complex presentations. And the authors say that although it's nuanced, these tools are not definitive for the diagnosis of ASD. There is no precise diagnosis around autism, and that's why there's an ongoing debate about whether it is a natural neurodiversity or whether there's an underlying biological disorder that affects brain development and behavior.
But I think autistic people don't see autism as a disorder that needs intervention. They view autism as an identity to be recognised, accommodated for, and accepted. And the National Autistic Society says that autistic people prefer using identity-first language, so they would prefer to be referred to as an autistic person rather than a person with autism. And similarly, they prefer the term outlook to prognosis, given that this is a lifelong condition and part of an autistic person's identity. So ultimately, though, this is the individual's own preference and may vary depending on that person.
True, and that is why the concept of treatments for autism is also debatable. There are so many unscientific, costly, and potentially hazardous treatments for autism, and there is no evidence to support any specific treatments that will change the core features of autism. So managing autism consists of behavioral interventions, such as those to encourage appropriate behavior, such as getting dressed or talking to other people, and to discourage inappropriate behavior, such as self-harm. Interventions that enhance communication or reduce anxiety through predictability and changes to the sensory environment can also be helpful. And vocational training for autistic individuals has been shown to be effective if the person's allowed to focus on their interests and strengths and where adjustments can be made to the social and sensory demands of the work.
Let's talk about ADHD next. According to NICE, ADHD is a behavioural syndrome characterised by hyperactivity, impulsivity and inattention. ADHD is not just kids who can't sit still. More and more adults are being diagnosed with ADHD, and the prevalence in the UK is 3 to 4%. A study published in March this year found that prescriptions for ADHD medications in the UK have risen annually by 18% since the pandemic. This is another one of those conditions that tends to get diagnosed more frequently in males than in females, and it's now known that girls and women are underdiagnosed, possibly because of how it presents.
And how does it look different in females?
Well, according to a learning module called Spotlight on ADHD by Dr Mafazal Rawala, there are 3 subtypes of ADHD. Firstly, inattentive, which accounts for 20 to 30% of cases. Secondly, hyperactive impulsive, which accounts for around 15% of cases. And the combined subtype, which accounts for 50% to 75% of cases. And because boys are more likely to present with disruptive behaviour, this is more likely to prompt a referral and consequently a diagnosis. On the other hand, girls more commonly have the inattentive subtype and are less likely to have oppositional defiant disorder and conduct disorder as well.
Interesting. And in adults, there are certain patterns that might hint that a person has ADHD. Having anxious thoughts, difficulty maintaining relationships, and difficulty coping in stressful situations are just a few of the challenges that a person with ADHD might face. And other patterns include frequent job changes, being frequently late for appointments, and choosing more active and less detail-oriented jobs. The MIMS Learning module goes into some detail about the symptoms and signs that might indicate ADHD.
Yes, and it says that emotional dysregulation has been recently identified as a core feature of ADHD. There are some red flags that might indicate emotional dysregulation, including emotional outbursts, impatience, irritability, hypersensitivity, and a low tolerance for frustration. And management of ADHD differs depending on the individual's age and the symptoms they experience. No medication should be offered to children below 5 who've been diagnosed with ADHD. In a child over 5, medication can be offered if, firstly, the ADHD symptoms persistently and significantly impair at least one specified area of functioning, even after implementing and reviewing environmental modifications. And secondly, the child and their parents and carers have discussed information about ADHD. And thirdly, a baseline assessment has been carried out. In adults, medications can be offered if symptoms still significantly impair at least one domain of functioning, even after implementing and reviewing environmental modifications.
Thanks for sharing that. Even though there's a lot more acceptance now than there was before, there's still a lot of stigma surrounding neurodivergence. People with ADHD, autism, or other neurodivergent conditions can feel that they aren't being heard or respected. Patients might even feel like their concerns about their conditions or what they're experiencing are being dismissed and not being taken seriously. What makes it worse is that people with ADHD may also have difficulties in social interaction. Clinicians may perceive this as rudeness.
Yes, there is research highlighting the stigma experienced by neurodivergent people when accessing healthcare services, so an awareness of this might be helpful for GP practices. We talked about the definitions of neurodiversity and neurodivergence at the start of this episode. Having this concept of neurodivergence as a frame of reference can help clinicians avoid using damaging descriptions of conditions and their probable outcomes. Autistic people and autistic children are extremely sensitive to how their condition is diagnosed and discussed, and they can become very distressed if the diagnosis and descriptions are not sensibly handled, even if they don't express this outwardly.
Exactly. In autism, anxiety in day-to-day life is a comorbidity, and this social anxiety may cause people to feel stressed. According to our clinical review on autism, autistic people tend to want to mask their symptoms in a bid to fit in, further worsening their anxiety. Stress amplifies the core features of ASD, and it can lead to behaviors like social withdrawal, shutdown, and meltdowns.
Dr Philips offers some useful advice to GPs on how they can work towards improving outcomes for neurodivergent people. The British Association for Neurodiversity and the RCGP Special Interest Group offer several useful resources to support clinicians. She says GPs should think neurodivergence for people who ask about it or present with behaviour indicative of it, and for patients who struggle to find solutions for their multiple problems. And this could make a big difference. Just one more thought from her.
I absolutely recognise the heart sink that comes when there appears to be a new kid on the block or a new flavour of the month. And ADHD diagnosis by TikTok can cause, I can imagine, a huge amount of frustration and cynicism amongst GPs. But I think it's a plea, really, that we do exist. It is real. Your colleagues, your friends, your loved ones, your teachers, your students, many of them, up to 20% of them, are neurodivergent. And actually, compassion and understanding and acknowledgement, not just the cynicism and the pushback, which I understand, but it's hard as a patient to have to deal with.
So I think that's really wise words from Dr. Philips there.
Yes, and the MIMS Learning module also speaks about the ABC of understanding and responding to autism, where A stands for acceptance for who they are and not trying to change them into someone they're not. B stands for belonging, recognizing that autistic individuals often feel like an outsider and they are often desperate to find the right niche where they do belong. And C stands for connection with someone who can offer trusted advice and support.
So I guess from the point of view of GPs, it's important to put yourself in the patient's shoes. And as Dr. Philips recommends, try to ensure that you're informed as possible about neurodivergence.
So what have we learned today? First, we learned that viewing neurodivergence not as a deficit or disorder, but as a natural variation of the human brain is an important perspective shift that can help clinicians move to support the patient better as an individual. Second, neurodivergence affects up to 20% of the population. Anxiety, depression, or emotional dysregulation might be a sign of an underlying neurodiverse condition, and these conditions are often comorbid with each other, so there is value in looking beyond the presenting complaint and thinking neurodivergence. Third, approach consultations with sensitivity, being careful of the language you choose to discuss the diagnosis. Approach consultations with compassion. Use neurodiversity-affirming terms to ensure that the patients feel heard and respected, and this can lead to better outcomes. Thank you for joining me in this discussion, Pat. Don't forget you can claim CPD credits for listening to these podcasts, and there are many more available. You can get your certificate along with links to the resources mentioned on our website, mimslearning.co.uk. In next week's episode, Rhiannon Ashman will speak to 2 breast cancer charities, Future Dreams and Breast Cancer Now. I'm really looking forward to that one. I hope you can tune in too. You've been listening to the MIMS Learning Clinical Update podcast, produced by Jude Owen. See you next week.